Therapy is a major advance in hematology, maybe in oncology in the future. And so I just wanted to have a little, uh, uh, sprinkle this. There's so much data. I want to give you a burst view of what's going on. So CAR T cell therapy uses a genetic construct here that usually the first generation, the simplest one, has a CD3 and a CD19, the first generation. If you put in a co-stimulatory signal and you enhance the cytotoxicity proliferation, the cytokine separation in vivo activity. But if you put more co-stimulating signals, you get a third, fourth, fifth generation of CAR T cells where you have improvement of all the above. So CAR T cell therapies, I compare that like a laboratory who produced the CAR T cell is like a restaurant, like a kitchen, right? They cook up with different side of dishes or products, and some of them taste good, works. Sometimes they don't work, and so the majority of the CAR T cells produced by a laboratory shows in vitro and in vivo preclinical activity. But when you use it in the humans, it either doesn't work or have severe toxicities. So the most popular four companies that proven to have a good product is the Memorial. They have, this is their construct. They use the retrovirus, and the NCI headed by James Kuykendorfer with retrovirus. This one is licensed to Kite Pharmacy, and then the UPenn licensed use the lentivirus that's licensed to Novartis. The MD Anderson do not use a viral vector. They use a transposase, basically the opening permeation of the membrane, so allow the genes to slip into the cells for gene therapy, and this is the sleeping beauty system. So this is by James Kuykendorfer. Works from the NCI. Dr. Kuykendorfer was a classmate, a desk mate of mine from NIH. He trained at MD Anderson with me. We are desk mate. We share the same desk. And so I'm very naturally drawn to Dr. Kuykendorfer's trials because before a lot of people dare to send him patients, I sent him numerous patients. So I'm the co-author of this paper. This is his construct. So he has a hinge transmembrane that's holding the antibody part, and then he has a T cell CD3 activation part, and then he has co-stimulating domain. So his trial works. He has the best data in large cell lymphoma. The UPenn has the best data in ALL and also CLL and the leukemia, but the Kuykendorfer has good data on the large cell lymphoma. So this is a large cell lymphoma patient before and after. Another patient before and after. This is actually primary mediastinal large B cell lymphoma, and so he has treated numerous patients, and then so you can see that the majority of the patients respond to therapy. Of course, he has his toxic deaths, like 3 or 4 of them. But now we are getting much better in dealing with the toxicity, and the death rate on these trials are generally decreased. So we first do apheresis, then we have to treat the patient with a usually fludarabine cyclophosphamide to deplete the lymphocytes. That will enhance the transfection of the CAR T cells in millions. Okay, so Jim has good data, and then Schuster from UPenn also presented the large cell lymphoma, one of his slides, that for the first time for the relapsed large cell lymphoma, we can see some plateauing of the curve. Of course, this is too small a trial. We need big phase 2 or phase 3 trials. So, and at this point, MD Anderson is involved in numerous CAR T cell trials. We have treated 10 patients with large cell lymphoma on the ZUMA-1 trial, which is a Kite Pharmacy trial. Relapsed large cell lymphoma, the response rate is just astonishing. You will hear this data in the coming ASH. And toxicity is bad. This is another patient treated at MD Anderson. You can see the baseline. This is 30 days after, and we have numerous pictures like this. It's too numerous for me to. All the 10 patients practically relapsed. I mean, responded. A lot of people in CR. This is the Sleeping Beauty system where we do not use the virus. The Sleeping Beauty system, the transfection rate is very low. And the beauty of the sleeping system is that the transfection is low. The CAR T cells that actually get activity in vivo is very low, and the efficacy is not there, but there's no toxicities, no cytokine storms. And so we use this after stem cell transplant, and we use that as for in the setting of minimal residual disease. We can see that these people who receive the Sleeping Beauty CAR T cells on a non-randomized basis looks pretty good compared with the historic data. So, and MD Anderson now, Lawrence Cooper now has moved to Boston to join the Zeo Farm and 2 companies. He had left MD Anderson when he is working on his CAR T cells using the Sleeping Beauty, but we are now developing an NK cell using cord blood. The same problem, the same approach. You just change the T cells to NK cells. We're developing this in a very fast. So CAR T cells are shown to be effective in CLL, good over ALL, and also the toxicity. I could spend like a half an hour or hour for the toxicity is very bad. So the cytokine release syndrome is one, and is caused by numerous CAR T cells appear suddenly in the bloodstream and in the CSF. So the cytokine release syndrome are high fever, hypotension. The 10 patients treated at Anderson, 4 of them went to ICU, but they came out. So 1 patient died from hemolytic anemia, but those are very, very severe. CAR T cell therapy is the most toxic therapy being tested in the clinical trials, in my opinion, short of allogeneic transplantation. So neurotoxicity is also severe. You can see the patient has you ask them to write something before, sign their name, and you will see the worsening of the signature and until they get better when they released out of the hospital. So toxicity is major problem. It's the number 1 challenge to CAR T cells. And the second challenge is that you have to make one product for every patient. It's time consuming, expensive, and laborious. So basically CAR T cells is moving the field forward. It is the hope for aggressive lymphomas like relapsed large cell lymphoma or like a mantle cell lymphoma blastoid variant. It's the answer to those aggressive tumors, but their toxicity is extremely high, and we hope with the time it will improve. But you can actually generate a CAR T cell from one donor to use it for multiple patients. How do you do that? You first knock off the HLA by either zinc finger technology or by CRISPR-Cas9, so you can get rid of the rejection of the T cells onto the donor cells. You could also knock out the T cell receptor, therefore get rid of the GVHD. So if you knock these 2 molecules out on those, and you can generate one product from one patient and use it on the shelf for multiple patients. So when this technology came out, the stock price dropped on all the CAR T cell companies, and this is off the record. And so also, CAR T cells, if they do not persist in the body and the tumor, they do not have efficacy. But if they persist too much, cytokine storm, neurotoxicity, and secondary malignancies. So the ideal thing is to have a switch. You can give a patient a pill. First of all, you make a lot of CAR T-cells there. You get your efficacy, and after you get your efficacy, you can turn off the system by giving the patient the pill. This is another. This is already very mature technology in breast cancer. Already did phase 1 clinical trials. So we're just using it for the CAR T cells. Thank you.
So that was the most positive, negative talk I've heard on CAR cells. But you know something, Michael? It was the most real one as well, because you're absolutely correct. I think this is a very promising technology, but it's very toxic and it's very costly. And I think that we're just in its starting stages of it. And the other thing I can say, because I obviously work with Jim, that these things have to be done in larger trials, because there is a lot of patient selection going on. I mean, it generally takes 2 or 3 months of wait in order to get on Jim's trials. And so there is a lot of selection going on. But as you well know, and I think you're probably part of this, Kite has a multi-center trial going, and I think that's going to be a very useful study, because we'll be able to see in kind of more of a real-world setting how useful is this. But I think that the technologies you're talking about today of getting a off-the-shelf one, I think that, to me, that, if this really does work, is really going to be the future.
Totally agreed.
And one of the things I've been hearing, that the move is a little bit to go to a lower number of infused cells. That gives 2 advantages. One is that they can actually start it sooner, and then they may have less of the cytokine storm. And then, since it's a living tissue, you might ultimately get up to the numbers you need. Do you think that's, is that the right way to go right now?
I think that's like adjusting the dose of chemotherapy, and you decrease the dose, you decrease toxicity, but you lose the efficacy. So I think really the future is in science. Is those switches, they can actually, if the patient doing good, they can let the system work. If the patient does not go to stop But this is a valid mix, and this is one of the many medicines. There's other pills. So the science is the only answer to that.
Yeah, I mean, actually, again, very small numbers, but when Jim dropped the numbers, it looked like the effectiveness dropped, just like Michael said. So I think it's like dialing down. It dials down toxicity, but it dials down effectiveness as well.
I would like to share with you a real-time story. There's this lady from South Carolina. She was in her 30s, and she married late, and she wanted to have a baby, and she was pregnant with the baby. At the same time, she was diagnosed with large cell lymphoma. And because large cell lymphoma was pretty aggressive, and after many consultations and academic setting, and she was offered chemotherapy. She absolutely declined chemotherapy. As this is my own chance for my child. I don't want any chemotherapy. So by the time she safely delivered the baby, she had bulky tumors. They started treating her disease with R-CHOP, RDAP. She failed all the chemotherapies. They said, one of the friends of mine said, you probably need to go to see Dr. Wang before you die. He came to Emily Anderson. I cannot give him hyper-CVAD because her counts and all that is not good. And so I said, I have a friend who is working on this CAR T-cell therapy at the NCI. But I have to tell you, he told me 2 or 3 of his patients has died. But quite a few patients responded. She said, I would like to go there. So she went there, got in the CAR T-cell therapy. Now 4 years after the therapy, she is still in complete remission.
Well, again, as we kind of mentioned, the immune system is as powerful to kill anything as you can if you can control it. And that's where the balance, because it's interesting, because I think it's the Memorial Group that is saying that they're still getting responses, similar responses with the lower, what they're doing, but that's with their construct. Again, I think like you said, we need bigger trials, we need randomized trials, we need to really say where it is and choose both, the patients and the right construct. But I agree with you, it is the science that'll take it. I think the switches, when you get talking about a live tissue, the switches are going to be one of the key things that you can abort, you know.
I mean, I think this is a very similar situation, although much more toxic to the idiotype vaccines. Idiotype vaccines have put people into CR, and some of Ron's very first patients, he's told me, are still there. So clearly, it works. But in this case, they're losing a lot of people as well. So if you do a large study, you may find that your chance of being cured is very low and your chance of being killed is very high. So I just think that it is a very premature therapy to think about using it as a general therapy. But I think it really holds tremendous promise.